Welcome to this, our new ISM Longcom seminar. This time we have an exciting topic to discuss as usual.
Today's topic, pandemic has occurred and it's been 3 years into the pandemic, but yet there are still rumblings of what coronavirus or its effects or its sequelae can do to vulnerable groups around the world, those with comorbidities, those with other risk factors and predisposition. So we are still seeing from time to time, and most frequently in some of the pockets where it is still there, renal effects with or without pathology. So without further ado, I would like to introduce Dr. Casado, Avila-Casado, to start this presentation.
Thank you, Surya. I have no disclosures for this. And our outline today will be that we will have, as an introduction, a clinical case that will open up some ideas and questions about what's happening with these patients with podocytopathies. I'll show the morphological findings, and then Dr. Sumant is going to show the molecular pathways involved in the development of podocyte injury after viral infections. So starting with the patient, this is a 60-year-old male. It's 8 years before we see this patient. He had a biopsy-proven podocytopathy that was classified as minimal change disease type. He received steroids, was treated, and was in remission. He had normal creatinine at that time. He responded very well. But in early 2022, he had a mild COVID-19 infection. And after that, he developed a nephrotic syndrome with massive proteinuria of 15 grams. He was again treated with steroids and then changed to cyclosporin because he didn't want to tolerate more steroids. He got some remission. But as you can see, in March of this year, he came again with mild viral symptoms, and then after that, he got proteinuria of 12 grams a day. This time, the creatinine was a little bit increased to 1.2, and then they decided a new renal biopsy, thinking there may be a different variant of podocytopathy. So a renal biopsy was performed, and the biopsy had 10 glomeruli, and there was not important findings in these glomeruli, excepting that they will be mildly retracted. They were not showing any endocapillary hypercellularity or any kind of inflammation. And as you can see here, I decided to show this panoramic slide also to show that the two interstitial well was very well preserved, and there was no inflammatory cells or abnormal tubular injury. This is a higher magnification of one of these glomeruli, and it doesn't show any important findings. The basement membranes were mildly prominent, and this is a 60-year-old, has no other comorbidities. And the other interesting thing finding in the biopsy is the presence of protein overload, and you can see the tubules are full of proteins filling these lysosomes. The immunofluorescence was completely negative for all kinds of immunoglobulins and complement, and the electron microscopy show what we were suspecting. There is important diffuse food process effacement in this low magnification. We can see all the capillary loops are surrounded by food processes that are not completely abnormal. There is a little bit of microvillus transformation as well. This is a higher magnification for the ones that are not used to see electron microscopy. We see this extensive food process effacement, sometimes with some concentration of the cytoskeleton. And other findings, the basement membranes were a little bit prominent, as we saw from the light microscopy. And other findings was the presence of endothelial hypertrophy. As you can see here, this honeycomb type of injury comes from this endothelial hypertrophy. There were no inflammatory cells and no deposits as we expected. So the summary of findings in this biopsy was the presence of protein overload, the absence of immunocomplex or by immunofluorescence, and the extensive food process effacement. So we come up with the diagnosis of diffuse podocytopathy without segmental scarring in a total, minimal change disease type, in a total of 18 glomeruli altogether, from the ones we saw from the light microscopy, immunofluorescence, and the ones we have in the blue section for electron microscopy. There was no arteriolopathy and no other interesting findings. So our questions now is, what are the triggers for the development of a podocytopathy after a common cold or other viral infections? What are the molecular pathways for diffuse polycytopathy? And so I would like to hand over the microphone to Dr. Sumant Chugh so we can hear about this.